Hello, my name is Ashish Havanur, and today I will be speaking about a disease called Konzo, which was first brought to my attention in my AP Human Geography class, where I studied disparities in this disease's spread, as well as the certain demographics it predominantly affected. But first, a little bit about myself. I'm a rising sophomore at Vista del Lago High School in Folsom, California. Some activities I'm currently involved in are regularly volunteering within my local American Red Cross chapter and my local middle school debate team, as well as in the Sacramento Veterans Affairs Hospital. And I also enjoy my role in my Vexed Robotics team as head of documentation. I'm also a Life Scout, currently working towards my Eagle Scout award. I am very interested in the fields of neurology and toxicology and how they relate back to public health. I am also an avid golfer and volleyball player, and I hope to pursue a career in medicine in the future. Now, on to the main topic for today, which is Konzo. It is described as tied legs in the Yaka language spoken in southwestern Congo, and this meaning will make sense and be explained later on in the presentation. But first, what is Konzo? Konzo is a neurological disease that was first discovered in the 1930s in what is now the Democratic Republic of Congo. Today, we see that the concentration of Konzo is still high within the DRC. According to the ANU Research School of Biology, there are over 100,000 cases of Konzo reported in the Democratic Republic of Congo, specifically amongst rural populations. And we will get into why it is specifically those demographics later on in the slides. This slide shows that in addition to the DRC, other countries in Central and East Africa, such as Mozambique, Tanzania, Cameroon, the Central African Republic, and Angola, all have reported cases of Konzo within, again, predominantly rural populations. Now, we move on to the primary cause behind Konzo. In 1980, Swedish physician and professor Hans Rosling, in collaboration with Thorkild Tyleskar, found that the very initial connection between disease and cassava, which is the type of plant that is regularly consumed in parts of Central and East Africa. A conclusion was made from these initial findings conducted by Rosling and Tyleskar that when the cassava plant was cut or peeled, it would actually release a certain amount of cyanide, which was further exacerbated during times of high stress for the plant, such as times in drought. Additionally, when this plant is not processed properly, the cyanide which was released from when it was cut can actually stay in the plant even when it is being used for consumption. This figure shows what takes place inside the plant when it is cut or peeled. Cassava plants naturally contain cyanogenic glycosides, and when the cassava plant is peeled or chopped, the enzymes in the plant actually break down the cyanogenic glycosides, creating cyanide, which is dangerous. Now, with proper processing, the cyanide can actually be removed. However, what we are seeing as a trend in these Central and East African countries is ill processing of these plants, leading for the cyanide to remain within the plants even when it is used for consumption. Now, cyanide consumed is very problematic to the human body, and this is when the disease called Konzo becomes more and more prevalent. So when somebody gets Konzo, it can have numerous effects on their body. This disease is an upper motor neuron disease, which means it can severely limit the physical mobility of an individual. Konzo specifically has immense effects on an individual's ability to walk, as it causes paralysis to the legs, which again ties back into the meaning I mentioned earlier, tied legs. This disease is seen more often within younger kids as well as younger women. In the image on the right, we can see the different severity levels of Konzo within these kids. The first one, which is mild, has weakness in the legs, but is still able to move without any assistance. The one in the middle, which is moderate, needs the help of an assisted device such as a cane or a crutch to be able to move. And the last case is the most severe case, in which he has lost all function of his legs. So when individuals contract this disease, further problems start for them and their family. An individual's economic mobility will be extremely limited after they contract Konzo because they can't work as well as they used to, or they can't work at all to support themselves or their family, which means there'll be a huge economic burden on themselves as well as their family. These individuals often also face enormous amounts of stigma surrounding their disease, and that can be problematic for a multitude of different reasons, such as mental health. So let's take a look at a recent case of Konzo. So recently there was a Konzo outbreak in Zambia. The numbers are shown on the slide, and we can see that this disease mainly affected young children. And when we look at the range of when we look at the range of the amount of cassava consumed, we can see it is extremely high, 4 to 21 times per week. And we could see that this data was recorded from a rural community with a high cassava diet, which falls exactly in line between the connection made earlier between cassava and Konzo. So now that you've seen the deteriorating effect that this disease has on your body and those around you, you may be asking, well, what is the cure? Well, currently there is no known cure for Konzo. Once Konzo is contracted, physical therapy is the best opportunity to regain strength. Doing strengthening exercises, range of motion exercises, and balance exercises is the best and most promising treatment for individuals who have already contracted Konzo. However, it cannot fully get rid of the disease, which leads me on to my call of action. Konzo is an entirely preventable disease in the first place if we focus and put emphasis on what the people really need. As mentioned before, the main demographic contracting Konzo are those rural populations, and this is because cassava is the only consistent food source available to them. They have no choice but to eat this cassava. As shown in the diagram on the right, many of these populations have no choice but to consume cassava due to factors such as agricultural crises or even poverty. By providing greater food security, we will decrease their reliance on cassava. Additionally, educating these communities on the dangers of producing or consuming unprocessed cassava will have a major impact as well. As for people who have already contracted Konzo, many of them are currently using makeshift assistive devices. So by providing them with the right to proper assistive devices such as wheelchairs and crutches, we can help to make their quality of life a lot better. Fundamentally, however, we as an international community should be taking action on this much neglected topic by providing funding to local and state governments, launching initiatives, and regularly monitoring the state of the disease. We can help to bring a certain end to this disease. These are my references. I want to thank the GHGLC team for bringing this program to us, and thank you to the audience for watching. And I hope we can all try to bring this disease more into light as an international community. Thank you.